Well, welcome back. We're going to start our next session, and it is After the Act, Lessons Learned and Benefits for the Broader Population After the End of Life Option Act Implementation. Our moderator is Lael Duncan, and it is my pleasure to introduce Lael, Medical Director for the Coalition for Compassionate Care, who will moderate the panel. Dr. Duncan is a licensed California physician with more than 15 years of clinical experience, practice internal medicine, infectious disease, and long-term acute care for patients with multi-system disease. She is an expert educator on POLST, end-of-life communication between patients and providers, advanced care planning, and the End-of-Life Option Act. Welcome to our Dr. Duncan.
Thank you, Carol. I just want to say thank you to all of you for being here and staying after lunch on the second day. We love to see continuous, excited engagement. I also want to say right up front that every time I address an audience that includes experts like yourselves in palliative care and patient care and spirituality and so many of the different perspectives that you bring, I not only feel that I'm preaching to the choir, but also am profoundly humbled by what you all bring to the organization and to the space and the place that you work and to the patients and families that you care for. So I really want to start with expressing my gratitude about that. So today, we have an opportunity to think a little bit retrospectively and I hope quite a bit prospectively about the End-of-Life Option Act, which was enacted, as you all know, in June of 2016. And what I would like to start with is a recognition of the fact that since the time of the passage of the legislation, a tremendous amount of work and thought and energy has been put into attending to the letter of the law, creating safe and effective policies for patients and families who have questions or concerns about this particular option. And a lot of education has been developed, many webinars and evening sessions and phone calls and notebooks, ethics committee meetings, tremendous number of hours. I would also like to recognize the fact that the passage of the act really did bring again into the spotlight, generally speaking, conversations about death and dying and about the experience that happens for patients and families facing serious, or in this case, terminal illness. And in this space of palliative care and serious illness care, we see that partly, I think, as an opportunity to say this is important for everyone. What we know is that the standard of care for those facing end of life is not equitable. There are significant disparities, there are geographical differences, and there are tremendous amounts of anxiety and physical pain and suffering, but also emotional pain and suffering. And those concerns are not unique to the population of patients who are interested in aid in dying, but they are representative of all patients who may be entering that space. So today, we are very fortunate to have some wonderful panelists. Dr. Nguyen is here again, and I will introduce all of them. And what we're going to do is take the time to think about this setting that we have now, where a whole lot of great work was done in thinking about how do we talk to and ensure a safe space and a safe place and a safe process for patients who are anticipating end of life. And we did that in the context of aid in dying. But how do we take that information, those policies, those lessons learned, and expand that out for a greater penetration and a larger, more sustained trickle-down effect for all of the patients who need these careful conversations. So we'll look at that in the context of the different settings where these individuals practice and work, and we'll think about it together, and I hope that we'll have time for some question and answer as we get to the end. So first I'd like to introduce our panelists. We have Dr. Vincent Nguyen, whom you met earlier, who is the director for the Hoag's CARES program. In partnership with the UCI School of Medicine, he's a founding member of the one-year Palliative Medicine Fellowship. He's board-certified hospice and palliative care specialist and also an excellent practitioner of geriatrics and family medicine. Next to him, we have John Tastad, familiar to many of you, I know. He is the coordinator for Advanced Care Planning Program at Sharp Health. He served as a spiritual care counselor at Sharp HospiceCare for 9 years. He teaches bioethics for new employees and volunteers at Sharp HospiceCare. And he serves on the bioethics committee regularly at Sharp Memorial Hospital, Sharp Grossmont Hospital, and Sharp Chula Vista Medical Center. And we are very fortunate and pleased to have Dr. Kauser Ahmed with us today. She is a PhD psychologist from UCLA. Her specialty area is patients with oncology, and she is the Associate Director of Training at the Mann-UCLA Center for Integrative Oncology. She played a critical role in establishing the psychosocial assessment and treatment protocols for the patients in the oncology clinics, and in particular for those who are requesting information about the End-of-Life Option Act. So we're very fortunate to have all these folks, and without further ado, I will plague them with questions. So, John, I'm wondering if we could possibly start with you. And I'm going to ask you to perhaps think back to before 2016 and set the stage for us in terms of what you feel was perhaps the quality and the prevalence of effective end-of-life care conversations as regards planning and making choices in your setting, and also in your region or other areas.
Thanks, Dr. Duncan. It is great to be up here and with all of you. At Sharp Healthcare, prior to the 2010, kind of the advent of the Affordable Care Act, as I began the Advanced Care Planning Department at Sharp Healthcare, it was a really, really difficult sell to talk about patient advocacy for informed decision-making, patients' right to forego treatment, patients' right to choose comprehensive comfort care over aggressive interventions. And advanced care planning, even advanced directives and post forms, were still a difficult sell. And we were all in around 2010 pretty enthusiastic about sort of a changing climate, and we had kind of all hammered away through post initiatives, through our local coalitions. There was a growing sense of patient empowerment for healthcare decision-making, and really a really strong desire to complete advanced directives growing through lots of community-based initiatives. There were things like the Dartmouth Atlas Project. There were the Institute of Medicine's report on dying in America that kind of pointed to some real tendencies that had been taking place to demonstrate that dying in America hadn't been particularly going well, and we didn't see a big alignment, if you will, between what a patient's preferences were at the end of life with what they were receiving at the end of life. And so it was an exciting time for us to begin to see things like National Healthcare Decisions Day, to see the Conversation Project, to see things like death cafes starting to spring up as we really focused on comprehensive community engagement and education opportunities to begin this empowerment of the patient to be able to name their substitute decision maker, identify their preferences for treatment near or at the end of life, and put in a medical order through the post form their preferences regarding immediate treatment preferences. So it was a pretty exciting time prior to the kind of some of the legislative discussions that were taking place related to the End-of-Life Option Act. And much of that then began to come into focus through the much publicized account of Brittany Maynard and some other cases that were in focus at the time. And there was a lot of discussion that occurred that kind of, I think, moved us more towards that deathing movement, that we had gone through the birthing movement and the transformation of our arrival into this world by redefining labor and delivery. And we've begun to explore new ways to reinvent, if you will, the departure from this life, or the deathing movement, this process of preparing for our departure with a great sense of control and empowerment. And so I think it was kind of in that context that the new law on June 9th, 2016 became something that we needed to reckon with. And most of us began policy-wise and procedurally and workflow-wise and ethically-wise kind of came late to the game in terms of preparing for the reality of that new law in that context.
Thank you. Dr. Nguyen, would you like to add anything about what was happening at Hoag and your region?
Sure. Well, the work that we've done through the Orange County Advanced Care Planning Partner started like in 2009. And this is before I came to Hoag. And when I was at Hoag, we began to continue doing the work with community education and advocacy. And at that same time, about several years ago, when there was alignment between St. Joseph and Hoag, and later with Providence Health, we saw some really, we saw the integration of Hoag becoming something bigger than itself, rather than the two hospitals in Newport Beach and Irvine. We became something much bigger within a system, and that's within the Catholic health system. So from what I gather was around October 2015, the California Catholic Conference and the Alliance of Catholic Healthcare basically appointed a leadership council having representations from each of these hospitals and the diocese to come together to figure out how do we respond to the to this advent of physician-assisted suicide in California, to provide care in an effective, loving, and a dignified way to care for people. And so I'll be talking a little bit more about that as we go along. So that's what I've seen, and this is the movement that we're doing. So the work that we do with the Orange Advanced Care Plan Partners mainly was for the outpatient arena. Now we're seeing the movement within the health system itself, within the Providence, St. Joseph, Hoag, and we're also seeing at the diocese and within the churches, local churches. So it's really exciting to see where the community coming together in response to the passage of the law.
Great, thank you. So I want to highlight a couple of things there. There has been momentum, and I think that was definitely something we were all feeling leading up to the passage of the law. Not momentum specifically for aid in dying, but really along the lines of the importance of advanced care planning and conversations, and we did see that with increasing social awareness. And Vince, you brought out the important role of communities in conjunction with health centers. And I think for all of us, that's a really, really important theme. It's that top-down and bottom-up approach to advanced care planning that we at the Coalition support. So thank you for bringing that up. I want to take I want to also discuss or present a little bit about the disparities that we see across the state. I know that's a bit of a challenge because we all work within our particular systems, but I'm wondering if we can start with you, Kauser, and I know you're at UCLA and we're going to explore your particular perspective, but if you could speak as a psychologist to some of the disparities that we see in the way or the where or the how these conversations historically have happened, that will also help us to understand the context for this discussion.
Sure. Thank you. Thank you for that question. So, yes, the conversations are culturally embedded. They're embedded in the lived experiences of patients and family members, and that includes, regional differences, access to health care, education, SES, how long people have to be on the road to simply be able to get to a physician, all of those things. And working at UCLA, an academic medical center, there is a bit of a sense of where we're at the kind of the ivory tower element of all of this. As much as I can speak for a giant institution, I think there was an awareness of the need to make really good quality healthcare accessible to all Californians, and not have them feel left out of the very best of care. And I know that particularly within the Department of Hematology Oncology, that effort has been realized in creating healthcare practices, hem-onc practices that are spread throughout the Southern California community, as far south as Laguna and as far north as Ventura. So that means folks literally can be accessing UCLA physicians, nurses, the best of clinical trials, and hopefully more and more the best of psychosocial whole person care in their home settings. What that's meant for us is that we also have had to adapt our understanding of how folks in different communities talk about healthcare, talk about health priorities, talk about their wishes for what quality of life means, how decisions are made when they're part of a very large, sort of more of a collectivist family, when the issues that come to bear really look different from community to community, and to take what we know about good care and be humble in the language and the listening that we do, so that we're able to really meet everyone's needs where they are and as they are, and to bring this kind of good care across Southern California.
Yes, great, thank you for that. John, would you like to add anything to that? I'd like to just have you expand on the concept of spreading a care model or a practice throughout an organization or into a community. How has that gone for Sharp?
Well, I think that because of our vast differences ethnically and with regards to religious preferences or our demographics in general, there's so much variability across all of our communities and then across all of our states that really does impact the response to this new option that was created in significant manner. And healthcare providers then, to add to that, have the legal right, of course, to adopt policies and protocols within their institutions that are very individualistic from another across the community, in our case at Sharp in San Diego, and across the state, of course. So everyone's sort of practicing the implementation process of policy in response to their institution, and then we're all trying to be really culturally sensitive and appropriate with regards to our implementation of our policies across the state. And I think that that's a factor with regards to End-of-Life Option Act.
Mm-hmm. Thank you. Vincent, I'd like to turn to you next. And I wonder if you can walk me through a little bit how your system has changed in the last 2 to 3 years, has grown in its ability to respond to patients, and how that has happened, and how you hope to see that move forward into the next phase.
Our stance has always been that physician-assisted suicide or physician aid in dying, while it's legal, we don't see it as being a moral or a loving response for people requesting to expedite the death. But what we practice, though, is, we were committed to collaborate with palliative care leadership, collaborating with CCCC, collaborating with CAPC, and palliative leaderships across the country to figure out how do we develop and deliver, really comprehensive medical and spiritual / pastoral care to care for the people at the end of life. It's really our goal, really, even the last 2 or 3 years, but we're working toward building a model in which we're able to replicate this not just in our little world here in Orange County, but how we replicate it through all the entire state of California, and to be able to share this with other systems who are interested in how do we respond this way. We touch upon with UCLA in a way where you want to provide the best care possible to your members or to your patients. It's about providing excellent medical treatments, but it's also we need to focus on the comfort and the spiritual well-being for the folks. So this is something that we're very interested in. So the way that we're rolling this out, there are people in this room who are leading this charge, and I'm just one member of doing this work. So if I happen to represent you, if I'm doing a great job, thanks, clap. If not, please raise your hand and pick up a microphone. Really, the best care possible is about caring for the whole person as we utilize. But how do we do that? We need to be able to strengthen the available palliative care programs as well. And the reason why we think about this is that, John touched upon what the Institute of Medicine has shared is people are dying badly. How do we respond to people dying badly is to figure out how do we change the system to improve it for them. And the other thing is develop and implement training programs. We have folks who are interested. Within the church, we focus upon clothing the naked, feeding the hungry, and sheltering the homelessness. So caring for people that are sick and vulnerable is really part of that response to people who are suffering at the end of life.
Yeah, thank you so much. So you're sort of showing us once again how important the palliative care team approach is, whether that's implemented through a specialty service or through a collaborative effort of primary services. That model for patients facing end of life is critically important, I think, for many of us. And yet we know from the California Healthcare Foundation's wonderful and extensive database that there are dramatic shortages and disparities of palliative care services and experts and healthcare workers across the state. How can we create, I want to say Band-Aid, but really sort of put some patches into place as we struggle to grow those services and create new systems for the patients who maybe are not fortunate enough to be in your system or your system or your system? And I wonder if we could think as a group for a minute about that, and I'll take maybe an answer from you first, Kauser. And as you begin that piece of it, could you tell a little bit about what has happened at Mann in terms of trying to explain, trying to educate non-palliative care doctors, non-ethicists, non-end-of-life psychologists about the importance of this work? Because I know you guys have done some really great stuff.
Absolutely. The question you asked initially about what has this, the challenge to implement this act, how has it changed the way that end-of-life care is provided across the board to all patients, I think is a really important question. And I would begin that by saying, by forcing everybody who is a provider to acknowledge that dying happens, even in the most cutting-edge healthcare system. And that's not a small thing. And that not only does dying happen, but that patients and their family members have real, cogent, thought-out, carefully considered, important perspectives about what dying looks like to them, what it means to them, what they want as they approach that, and as they move through their trajectory of treatment along the entire spectrum. As psychologists, as the folks on the psychosocial end, we have no access to prescription pads. We don't prescribe drugs. We don't do anything in
no
that.
Psychedelics for your patients.
And no psychedelics either. But what we do is that we are at ground zero for when those first conversations happen. You can't tell someone that they are dealing with a cancer diagnosis without having them immediately think about, what does this mean for the rest of my life, and how long my life will be, and what does this mean for my dying? So we're invited into those conversations almost immediately and develop a certain kind of familiarity and comfort and, as I said before, an understanding of the unique language of that particular person and that particular family in what they can address and what they have difficulty with. That allows us to be able to continue those conversations as we move forward. I think what's happened at UCLA through the implementation of this act, and I have my wonderful colleagues, Dr. Annie Walling and Jenny Kung back there, is that it forced us as a system to really think about how do we do this as a team of people who are caring for these patients, regardless of what our specialty is, regardless of whether we're oncologists, we're nurse practitioners, we're palliative care docs, we're psychologists, social workers. We all have a role to play. We all have conversations to be having, and to not prioritize one set of conversations over another, but to really integrate them and to pull that together. Annie Walling and some of our other colleagues wrote a wonderful article about a shared mental model of care, and how do you implement that? How do you help a system to communicate about a shared mental model, about what care looks like, and that includes practical things like having a tab for advanced care directives and goals of care that's accessible to every physician, every provider, every nurse, providing ongoing training to everyone about how do you look for openings for talking about goals of care, how do you make yourself available for that, how do you move those conversations along, and then really how not to think about living and dying as black and white and along a linear spectrum, but truly to embrace yourself as a provider, the multiplicity of hopes and fears and possibilities that our patients are living with every day, and how do we support them in the conversations that we are open to having with them, and then documenting those conversations and using those conversations to really develop plans that help them and that evolve with them. I'm not sure I answered your question, but
I'll come back to my question. You're not off the hook. So you mentioned the importance of process and training. Obviously, tracking documents and being able to keep track of information is critical, partly because that system is what outlives a warm body that you've trained, and that's so important as we hope to leave a legacy of caring and of practices that honor each patient. So let me address you again, John, and tell us a little bit about the process that you use in SHARP to ensure that these conversations are being held with patients who are experiencing or have been given a terminal diagnosis. And please also share with the room, do you think it's happening regularly in all the settings where it could be or should be? And how do you see that at this point in time?
Yeah, I think at SHARP we've had a real strong commitment, like Dr. Nguyen at Hoag, to really up the game with regards to palliative response to patients' inquiries for support and physician requests for assistance with those difficult conversations. So our inpatient palliative care presence has really grown. Historically we've had a fantastic outpatient or home-based, community-based palliative care program through Dr. Hofer's initiative in Transitions, where it's that documentation and that conversation is built into that. In terms of documentation, stewardship, review, we have worked diligently with our processes and our electronic medical record just to make sure that conversations are more visible than ever before on the EMR for all clinicians in multidisciplinary fashion. One of the things I wanted to say, however, was that these questions were specifically related to requests to hasten death have been happening for a long, long time, not only at SHARP Healthcare, but at every healthcare facility across the state, and well in advance, years in advance of the passage of the End-of-Life Option Act. And that for us, I think it's been an ongoing learning curve through palliative education and different inpatient and outpatient teams to respond to that conversation request with increasing skill, and to more skillfully when someone says, geez, I don't even know if I can go on another day. God, do you have that pill? I read about that pill. Can you give me the pill? I'm really depressed and I don't know if I want to go through more treatment. Can you tell me about the new law? And sort of these, sometimes veiled requests for what we might identify initially as, the flashing lights and the bells go off and, oh, it's an End-of-Life Option Act inquiry, and we might have we don't at Sharp have a specified team of FTEs that respond only to those requests. That happens within the context of our inpatient palliative care teams. We do have an outpatient team that will respond to those requests for information, and we don't have a prohibitory stance within our policy that disallows any physicians to participate on behalf of Sharp in that option. So we do respond, I think, really skillfully with regards to those inquiries, as we have for decades. Now with a new twist that there are some legal requirements depending upon the nature of that request and where that goes. And lastly, I just wanted to say, I think that those requests to hasten death are frequent and they're normal, and sometimes they're passing, sometimes they're a little bit more consistent, and sometimes there are steps taken by those individuals, and it takes extraordinary skill to dissect the nature of the question that's being asked to facilitate the most appropriate response to provide excellent palliative support care for that particular patient.
So I'm wondering, given that it takes extraordinary skill and finesse, and yet patients have these concerns across the board in many, many different types of settings, and they won't be lucky enough to be on your inpatient palliative care service. And yet, as professionals and educators, it really is on our table right now to try and push some of this understanding out into the broader world. So sometimes I start some of my presentations with just a number, which is 245,000. Does anybody know what that number is? That is the number of people who die every year in California. That's a big, that's a big, big number. And if we are going to provide, and let's say many of those are from trauma or something very sudden, but many of them, and a growing number of them are going to be older with complex medical illness, multiple comorbidities, and are going to need this kind of care and conversation, the mental model that you described, Kauser. So what specifically can we do as leaders, and everyone in this room, I charge you, to bring our colleagues and our friends and our families into the understanding and the skill space so that these conversations and this kind of care can happen more generally speaking outside of the silos. Shall I start with you, Vince?
Yes, I'd love to tackle that one. I mean, I'm very fortunate to work in a very beautiful hospital with lots of resources and so forth. And people and families are really appreciative of how lucky they are to be at Hoag to receive such wonderful palliative care from our team. But that's wonderful to hear, but you often think about, well, what about those people who don't have access to palliative care? What are people who don't go to Hoag? They may go to another hospital down the street. And so one of the beauty I see is with the SB 1004, it really expands palliative care services to those who are underserved. But then there's not a whole lot of us to be able to go out there and reach these people with these, let us help you with these wonderful resources that we have. And so how do we bridge that is, I really think the next stage is really with telehealth. And this is something that I'm bridging upon, and really work with health plans, working with, with payers to see how can we bring telehealth to those people who are just too darn weak to go in to see me in a clinic, or maybe the only time to get to see me is when they end up in the emergency room or in the ICU or hospital. So how do we create a model to bring care to the patients and family and train the forces to do that? And so in our program, we're very committed not to just training physicians and fellows, but we train, we have a pastoral program. We also have interns, residents, and social workers and so forth, and PAs and NPs who rotate with us. And we say, well, maybe we can't do a whole lot for the community, but at least we can only do what we can with what we have. And we're going to continue to build and inspire and instill to those people who come to us and say, well, you're charged to go out there and start the domino piece rolling. And that's what the perspective I have regarding this.
Great, that's really important work. So teaching and educating others, role modeling, I think growing the workforce in any way we can, and then extending the workforce through technology like telehealth. All great points. Kauser, I'd like to come back to you for a minute. You work in a very unique setting. You call it an ivory tower. I think many of us do. It's the Holy Mecca. And many patients go to your facility because they believe that they're hoping for that miracle, that they will get the top of the line, the most experimental, the most amazing. So there's a mindset among many of your patients that may make advanced care planning quite challenging. And in this stage, how do you feel the impact of the work that you've been doing at Mann and with the oncology patients? Is that growing outward into the general population of UCLA patients, and in particular down into the primary care clinics or the specialty care clinics where we know those patients are somewhere on that trajectory? How is that going for you?
I'd like to say that it was further along. It isn't quite yet, but I think what is happening is an awareness that these concerns exist among all of our patients, and that all providers at UCLA have a responsibility to be open to the kinds of questions and the conversations that are needed. We are providing that kind of training, as you mentioned, as Dr. Nguyen mentioned, to fellows, to NPs, to nurses, to our interns, social workers, everywhere within the system. And I think it is about, partly breaking out of that hierarchy of the only conversation that matters is the one that you have with your physician, and the only conversation that matters is what your physician says to you. So part of the work that we do and that we want to spread is empowering our patients as well and educating them in how to have difficult conversations. In the article that Dr. Walling wrote, there's a lovely definition of the work of palliative care as facilitating understanding of patients' needs for physicians and vice versa, facilitating physicians' worldview to patients. And one of the most important things that I do for my patients is sit down with them and say, when you talk to your doctor, what feels like gets in the way? What would you most like your doctor to know? What do you need them to understand about what you're struggling with physically, what you're struggling with in your quality of life? And can we talk about what your goals and your hopes are, what you'd like to be able to achieve, and invite them into a conversation about how do we do this together? And I actually got to witness one of my patients who kindly invited me into the consultation room with her physician, and the physician nervously allowed me to be there. And I could see where they kept missing each other, where he kept wanting to talk about statistics and numbers and studies, and she kept wanting to talk about, but what will I be able to do and what will I not be able to do? And with just a little bit of preparation that she and I had done beforehand, she had a list in front of her where she could say, so here's what I'm thinking I'd like to be able to do in the next 6 months. And can you tell me, I know you don't have a crystal ball, I told her, you gotta get that out of the way, say it before he does. You don't have a crystal ball, but based on your expertise, your knowledge, and your work with other patients like me, can you help guide me about what is doable here? And one of the items on her list was she'd fallen in love with an apartment that she wanted to buy and renovate, and this was a really, really special, important dream for her. And I watched him take a deep breath, and I could see how hard it was for him, and this was the last conversation he wanted to be having, but he actually said, I'm not sure that you have 6 months to be able to do that. And she took a deep breath and said, thank you so much. You have no idea how helpful this is to me. And they both breathed, and they were in a different conversation and a different relationship. And they went about taking care of what needed to be taken care of because of that very simple intervention. And that you don't need to have a PhD to be able to do. You don't need to be a palliative care doctor. That's something that all of us can be thinking about, and we can take to our loved ones, our patients, take to everyone who ultimately at some point, all of us included, are going to be in the position of having those conversations. And can we help our physicians to have them with us?
The role of patient empowerment.
Yes.
I love it. So we only have a couple minutes left, and so I'd like to give each of the panelists maybe just a minute or two to make any recommendations that they might, as high priority items for moving conversations upstream, for assisting colleagues to learn some of these nuanced conversation skills, or just to raise awareness about the need to listen to the patient first. Any of those things. So I'd like to, we'll start with Vince, if that's all right.
I started saying that, caring for the person, we care for the whole person medically and socially. And when people die badly, we see that as a public health concern. And with any public health concerns, we put programs and things together to help people. So when we talk about people who are dying and with a serious illness, we take care of the public health concern by not alleviating the illness by getting rid of the person with the illness, but try to figure out what's the underlying cause and help them through this. So this is really a challenge to our health system. It's not asking us to take the easy way out, but how do we come together as a system to solve this public health? And having this conversation, how do we walk together? How do we journey together? Accepting, yes, there's differences in our philosophical upbringings or how we approach this, but we really are focusing how to improve care for people at the end of life. And it challenges us because it's also caused what I see as a productive friction. And through this productive friction, I think we can make a better way of how to care for people much better, with excellent medical care, with compassion, with kindness, and all the goody two-shoes on there with a cherry on top. So thank you.
Thank you. So I'm getting the dreaded 0-minute time card, the cutoff sign. I'm going to give my panelists 15 seconds to say whatever. If you have a gold nugget, now is the time.
I've just talked to so many patients who've had inquiries about the End-of-Life Option Act, and they often begin with the statement, I just don't want to suffer. But the reality is that all of us here know that the physical side of that suffering is what we take care of in great palliative care upstream and end-of-life care and hospice. So get involved in your local coalition and promote palliative care. Get involved on a state level through the CCCC, because I think that so many times the inquiry is because we just have more work to do about getting the news out about how phenomenally we can control suffering. The existential end of the issues that lead to the inquiries are oftentimes what drives that question, and fears and things that aren't necessarily related to physical suffering. And we need to keep developing new tools to more aggressively address the existential or the demoralization syndrome that pops up with regards to patients who make these requests.
All right.
Really quickly, echoing everything that's been said, If you're part of a system that treats disease, you may or may not be successful. If you're part of a system and a team that cares for and treats a person, you can't fail.
So I want to thank my panelists really for a good discussion. Thank you so much.